The kind invitation excellently organized seminar, and I am very privileged to be giving a talk on a very important topic about GERD. Quite a lot to pack in 15 minutes, but I'll try my best. So, first of all, today's talk is about both pathophysiology and also diagnosis of GERD. I'd like to go back a little bit to the definition. So, GERD is defined by the presence of troublesome symptoms or mucosal lesion due to the reflux of gastric content into the esophagus. And it's important to recognize the different type of GERD. There can be NERD, and basically is what we call non-erosive reflux disease. So the patient probably will present to you with highlighted in red by troublesome symptoms, or the patient may present with erosive reflux diseases, which are essentially as a consequence of the mucosal lesion due to the reflux of the gastric content. And of course, some patient might present, and there are many other terms which describe GERD, and probably you'd like to know the meaning of the various definitions, for example, what's meant by factory GERD, or various what we call phenotyping of GERD, and which I'll go a little bit on that later. So this diagram you probably might have seen before in other talks. So basically GERD is a wide spectrum of diseases, and it depends a lot on whether there's the amount of acid exposure in the esophagus, and also in the level of the esophageal hypersensitivity in the patient. And for example, if the acid exposure is very severe, patient obviously will have a lot of mucosal damage, which in some cases, if the patient is not very sensitive in terms of the symptom, they may not present with anything. They can just present, for example, in rare cases, even anemia. But on the other hand, some patients might have sort of minimal mucosal damage, but while they have a lot of symptoms, probably they are related to esophageal hypersensitivity. But for all intents and purposes, for diagnosis of GERD per se, the part that the acid exposure is considered normal, which we have a term called functional heartburn, these are not GERD. So what is the pathophysiology of GERD? So basically we're talking about the reflux of the content from the gastric side to the esophageal side, which is something that physiologically we do not want it to happen, and our body has some natural mechanism to prevent it from happening. So it's something what we call the anti-reflux mechanism or barrier. It's constituted by several mechanical or physiological phenomena. First of all, we have the lower esophageal sphincter, which is where the OG junction is. And also it usually is in conjunction with the diaphragm. They work hand in hand to provide the anti-reflux barrier. And also very importantly, and sometimes overlooked, component of anti-reflux barrier will be the esophageal peristalsis itself, because inevitably we might have something that go up to the esophagus, and it's very important that the esophagus can have a built-in mechanism to push down the content down to the stomach, so that the exposure time of the acidic content in the esophagus is minimal, and it's actually a very important part of the anti-reflux barrier as well. So what would lead to GERD is reflux content is when the intragastric pressure can't overcome the anti-reflux barrier, then reflux of the gastric content to the esophagus would occur. So it's a fine balance between, or you can say it's kind of a balance between the two forces. And when there are problems with one or the other, then it would lead to occurrence of reflux of gastric content. For example, in the anti-reflux barrier, if there are problems with the lower esophageal sphincter, maybe because of the laxity of the tone of the LES, or in some cases there may be a term called transient relaxation of the LES. Obviously, it can lead to an easy reflux of content. In terms of the diaphragm, there may be hiatus hernia, lead to malunion or disruption in the integrity of the anti-reflux barrier. And for esophageal peristalsis, sometimes in patients with, for example, IEM, and then in those cases, the patient, even when the acid content reflux back to the esophagus, they fail to clear the content, obviously can lead to development of GERD. While on the other hand, some factor that lead to increased intragastric pressure would also be very conductive of leading to reflux gastric content. For example, central obesity obviously would lead to increased intra-abdominal pressure and translate into increased intragastric pressure. Also, patient taking very heavy or late meal. A heavy meal means the content in the gastric would be a lot more, and also late meal means the patient, when they lie down before the gastric content are completely cleared, without the aid of gravity, the intragastric pressure would increase as well. Sometimes the food also play a role. For example, very sugary or oily food, in general, the stomach needs more time to digest that. So when the longer the food content stay in the stomach, then the amount of time that there is high intragastric pressure would be more. So all these are kind of conductive to occurrence of exit reflux. And I would say this is good to understand this part of pathophysiology, because that would make your advice of lifestyle modification makes more sense. So what tests are available, and this is part of the diagnosis of GERD, which is an extremely big topic, and I would say also quite a lot of debate. And first of all, of course, I'm talking about tests, but of course I think one of the most important is we talk to the patient and understand the symptomatology. But on the other hand, we want to, in terms of tests available, there are a lot of questionnaires like the GERD-Q, and the PBI trial is very commonly adopted in clinical practice and also part of the usual suggested management algorithm. And but I like to focus more on what we might do. For example, OGD, we want to do it whether the patient will be on PPI or we need the patient to stop PPI beforehand, and together with many other tests that I'm going to elaborate more later. And one of the most key guideline about diagnosis of GERD, I'm sure all of you will be familiar with, is the Lyon consensus. It's been the latest is updated to be the Lyon 2.0 consensus. It's a very comprehensive guideline. If you see a very busy diagram, and you probably will see it in a lot of talk on GERD, about how to make use of the finding of some usual GERD tests in order to diagnose GERD, and actually not in terms of diagnosis GERD in terms of black and white, but kind of diagnose GERD with a certain level of confidence. And I'd like to tease out the diagram to you, and that in essence, despite the busy diagram, we are mainly talking about several key investigation being mentioned in the Lyon consensus. One is the endoscopy, which is the OGD. Second is esophageal pH study, be it pH alone or pH impedance, and third would be some features on manometry. So first of all, going to OGD, I think almost all of you would have some experience with performing OGD, and we kind of do OGD in the same way, but probably when it comes to GERD, you want to do it kind of differently, because it's a very important station of investigation, because first of all, you want to make sure that patient only present with GERD, but not other more sensitive pathology like esophageal cancer. And OGD is useful because it can, you can potentially already diagnose erosive reflux esophagitis, and it can offer some supportive evidence of nerve, and also now we can, during the OGD, we can also perform some endoscopy-associated procedure like wireless PEEP capsule, flip, or maybe direct mucosal impedance measurement. So this is a very nice journal which I capture some diagram. In the OGD, there are some essential things that I usually would record. First of all, I would like to record the OG junction valve, because and remember that the endogenous barrier is a valve. So actually, ideally, you don't just want to do a retroflex and then take a photo. You want to adequately insufflate the stomach, because you want to evaluate the OG junction as a valve. So supposedly, you want to insufflate the air, the stomach. I will do the CO2 sufficiently in order to look at the valve as a valve mechanism. And there are many classifications, for example, the Hughes valve criteria, and also you want to look at the OG junction to, for example, document whether there are any evidence of erosive reflux esophagitis, be it airway reflux esophagitis, or Barrett's esophagus. And now there are some we would push it further. Beside airway class A, B, C, D, there are some, there's an entity called minimal change esophagitis. So basically, they look at kind of a more detailed assessment of the OG junction and look for example, some quite minute or subtle changes like erythema or increased vascularity that might suggest for underlying GERD. But I emphasize these are kind of supportive evidence and not diagnostic of GERD per se. And this is just to show you what a red esophagus would look like, which I'm sure you're all familiar with. And you want to describe it as according to the, for example, Clark classification. So as I mentioned, OGD can be diagnostic of erosive reflux disease. So in accordance to the Leon 2.0, now airway grade B, C or D esophagitis, biopsy proven Barrett esophagitis, Barrett esophagus, and also peptic stricture are conclusive already. So you could potentially diagnose GERD ERD based on OGD by itself. And ideally, because you don't want it to be a kind of false negative result, ideally you want the patient to discontinue PPI adequately before you perform the OGD. And sometimes in patient with very severe esophagitis, you could repeat the endoscopy after adequate PPI therapy because while after the esophagitis heals, it could unmask, for example, Barrett esophagus. And next, I'll move on to the esophageal acid study. So we have several options, and I think we have some hands-on workshop. We probably want to elaborate a little bit on that later. So I'm not going into very technical detail, but in essence, we are spoiled with options. We can do it with the catheter itself, or we can do it with the wireless pH. And in terms of doing with the catheter alone, we can choose whether to do it just pH study or do it with the impedance. So the thing that we can obtain from the pig study, so basically the spirit of the test is you want to test the level of pH exposure in the distal esophagus. There are a number of parameters that we can obtain from the study as listed here, and usually the 6 parameters are combined into a composite score called the Lister score. And the most important metrics would be first in the total percentage of time where the pH is less than 4.0 is something that we call AET, and also the total number of reflux. And I think it's definitely beyond the scope of this talk, but I think there's some controversy in terms of the AET cutoff in Asian. There are some studies that found that probably the AET in Asian, which will translate into the cutoff for the Lister score in Asian, is probably less than that we call in the investment population. And but this is something that you probably want to just bear in mind. And beside the pH parameter, we also would want to look at whether the reflux has any correlation with the symptom, which will be the reported symptoms by the patient during the pH study. And there are some parameters that you can look at to determine whether the symptom correlation is positive or negative, which I believe we would like to go through that in the hands-on workshop in the afternoon. So besides catheter-based, and now we have some wireless reflux study. We have several brands. So basically these are deployed mostly during the OGD, and deployment of the capsule will be 6 a.m. about the OG junction. And the advantage of that is patients do not have a catheter sticking out, so they are more likely to reproduce their usual daily activity and representative of their usual kind of reflux phenomenon, because as we know, probably reflux is also very heavily influenced by their living habit and eating and so on. And now the equipment is very updated, so we can do prolonged pH monitoring. For catheter-based, usually we can only do 1 day, but for wireless capsule, we can do it up to 4 days, 96 hours. And we have options to do it off PPI, on PPI, or because we have 4 days, we can even do the first 2 days to be off PPI, and the last 2 days to be on PPI. So look at the both the off PPI study and also the effect or advantage of PPI therapy. But we don't, for pH study, we don't necessarily only look at the exit. We want to look at something called impedance. So impedance is, in physical terms, resistance of electrical conductance. As you know, it will decrease when the presence of fluid is more conductive of electricity, or on the other hand, if there's presence of air, the electricity doesn't conduct. So if we look at the luminal impedance across the whole esophagus, we can detect also presence or absence of fluid, and also we can make use of this to let us know whether there's any presence of reflux. So if we put in a catheter and measure the impedance across the esophagus, we can actually directly look at determine whether there are any reflux episode during the examination, because sometimes the content of the gastric content being refluxed up to the esophagus are not necessarily acidic, and they might also cause problems. So if we have additional evidence of impedance, we can know whether the patient actually suffers from weak acidic reflux or non-acidic reflux. Mind you, the test itself is quite difficult and time-consuming to interpret. And now we know that impedance, besides looking at just the flow of the content, itself is a good measurement of the mucosal integrity of the mucosa, because, as I mentioned, if the acid exposure can cause a variety of damage, sometimes it's very easy on the eye. For example, we can even look at any presence of ulcer, for example, but sometimes they may not be very easily be looked at endoscopically, but there are already some damage, for example, in the cell level, as reflected by, for example, more leaky esophageal mucosa, what we call problem with the cell junction. So in that cases, the patient might have, if we measure the baseline mucosal impedance, the electrical conductance of the mucosa alone, and we can pick up cases that have evidence of acid exposure that are yet or do not severe enough to develop into frank mucosal lesion. So therefore, making use of the luminal impedance, for example, during 24-hour peak study, we can measure some important metric, for example, called the MMDI, measure the baseline impedance of the mucosa to see whether there are any likelihood that the patient might have some already have some minimal mucosal change due to the irritation of the acid. And also there are some new devices that already during the endoscopy, you can directly measure the mucosal impedance of the distal esophagus to tell whether there are any likelihood of development of GERD. So besides the diagnostic tests, there are some important adjunct tests that we would do in terms of management of GERD. And for example, manometry, very important, obviously, but it's not diagnostic of GERD alone, but as mentioned in previous talk, extremely important in the management of GERD as a whole, because, for example, we want to do a catheter-based exam, you need to localize the LES, and also we need to rule out major motility disorder. The reason why is that I very quickly go through this paper is that sometimes in major motility disorder like achalasia, if you just perform the peak study, it can become positive, but it's not related to acid reflux. For example, in achalasia, as shown by this study, is something called fermentation phenomenon. Retained content in the distal esophagus alone can lead to fermentation and acidification of the content. So you need to do manometry to rule out major motility disorder, so that you will not manage them in the wrong way. And manometry also is useful because now there are some additional metrics that are helpful in predicting the likelihood of GERD. For example, something called strict leg raising maneuver, shown to be very useful in terms of proposing the likelihood of GERD. And now we have this Milan score. This is actually an app you can download freely on your phone. I have it on my phone as well. There are some metrics that you can use through the manometry alone, and that they can have a composite score of the likelihood of development of GERD. So, whether, for example, you can see whether the patient has presence of IEM, you can see the patient response to the strict leg raising, and also the baseline LES contractile tone in terms of the EGG contractile interval and the type of EGJ type, and also the composite score of the likelihood of GERD. But by itself, it's not yet in the Lyon consensus in terms of diagnosis of GERD, but I think personally it's quite useful. And FLIP, I'll keep it very short. Professor Dow already mentioned what FLIP is about. In short, FLIP itself is good in terms of knowing whether the area is tight or loose, but by itself it's not diagnostic of GERD. We have some data that suggests it's not diagnostic of GERD, which is not surprising because, as we know, as I mentioned, the pathophysiology, the laxity of areas alone is only one part of the anti-reflux barrier. So probably even though we know the areas is very loose, it doesn't mean the patient necessarily has GERD because the underlying pathophysiology of GERD is very complex. So last couple of slides. So what tests to do? So I think you would meet with possible clinical scenario. One is you want to diagnose GERD. Patient present with possible GERD, or patient already managed with GERD and they come to us. So in terms of diagnosis, patient yet to have diagnosis with GERD, I recommend that you can do, of course you want to do OGD, to rule out other pathology, and maybe OGD already is diagnostic of ERD, and if the OGD is not positive, then you want to know whether the patient has NERD or not, then you should probably proceed with a spatial quick study while the patient is not on PPI, because you don't want to have false negative results. And the choice of the quick study, be it catheter-based or wireless, it probably will depend on the local resources available and the cost concern and probably patient preference. And on the other hand, if the patient is already on treatment of GERD and refer to us, for example, they present with some persistent symptoms, what to do? So you want to ask yourself, I was asking myself, was the GERD diagnosed correctly in the first place? If probably it was not so-called meticulously diagnosed, probably you want to go back to the diagnostic workup and see if you need to do anything to diagnose the GERD or see whether the patient has something else. Now, if the GERD is already adequately diagnosed but the patient has refractory symptoms, in those rare cases, you might want to examine whether the patient has PPI treatment failure. Only in those cases you want to do the isofacial case study, consider it when the patient on PPI. But I think those cases will be relatively rare. And lastly, in patients that would be considered for anti-reflux procedure, they may have value on menology or FIP. So that concludes my talk. Sorry for the opening. Thank you very much.